Laparoscopic component separation. Component separation is a technique that involves elevating flaps and releasing the external oblique to allow myofascial advancement flaps. Typically, 8 centimeters can be gained of advancement from unilateral separation at the umbilicus. However, this procedure requires extensive flap dissection to approach the external oblique, and without preservation of the perforator vessels, ischemia can result, as well as skin flap necrosis and infections. Recently, Moss et al. Presented 4 cases of endoscopically assisted component separation without any major wound complications. We present a 53-year-old gentleman who is obese with insulin-dependent diabetes, who presented with an infection after a piece of composites mesh had been used for an open hernia repair. After resection of the infected mesh, he was left with a fairly large defect that required component separation to repair. Here you can see a 10-millimeter incision is made off the tip of the 11th rib. Using S retractors, the external oblique fascia is identified and controlled with pediatric Coker clamps. The external oblique fascia is then sharply incised, and the potential space is entered within the external and internal oblique lateral to the rectus muscle. This space is initially bluntly dissected to gain appropriate access. Next, a laparoscopic inguinal hernia bilateral balloon dissector is placed in this space down to the anterior superior iliac spine. Under laparoscopic visualization, this is insufflated to accentuate the space within the external and internal oblique. As you can see on the bottom of the screen, the internal oblique is swept inferiorly, and on the top of the screen, the fibers of the external oblique are used to separate and create this potential space. This balloon is then removed, and a 10-millimeter blunt tip balloon port with a 30 cc balloon is used to create and maintain pneumoperitoneum. The space is insufflated to 10 millimeters of mercury, and a laparoscopic camera is used to visualize and bluntly increase the working space. This is the laparoscopic visualization once the balloon has been placed. Again, the external oblique is on the top of the screen, and the internal oblique is on the base of the screen. And to the left of the screen is the linea semilunaris. As you can see, using the balloon dissector, we are able to dissect far lateral on this patient to the anterior superior iliac spine, as you can see demonstrated here, and to the posterior axillary line at the point where the lateral neurovascular bundles enter. 2 5-millimeter ports are placed to complete the dissection. One is placed inferiorly just above the inguinal ligament. Using this port under laparoscopic visualization, the potential space is dissected further, bluntly sweeping away the avascular adhesions to create an adequate release for working space. This again is taken down far laterally and up to the costal margin. Once the tip of the 12th rib is identified, the dissection is complete and a lateral 5-millimeter port is placed. At that point, using scissors and cautery, 2 centimeters lateral to the rectus complex, the external oblique is released from the myofascial complex. This is done under laparoscopic visualization, extending down to the inguinal ligament inferiorly. The dissection is continued superiorly up on top of the costal margin to perform a complete release of the external oblique complex. Again, laparoscopic visualization as the dissection is carried up along the costal margin. At the superior aspect The muscle fibers of the external oblique are divided using cautery as this is continued over the costal margin. At that point, you can see adequate release is gained to reapproximate the fascia in the midline. Given the extensive defect and some tension as well as the tenuous fascia, bilateral component separations were completed. The contralateral side is again entered using the balloon dissector, and the space is bluntly created under laparoscopic visualization. After placing the two 5mm ports, the space is again bluntly created, releasing the internal and external oblique muscles. Again, if there is any concern over the depth of the release, a hand can be placed within the laparotomy incision to confirm safe placements. The dissection is continued posterior laterally until another 5mm port can be placed. And again, the external oblique complex is released from the rectus abdominis, 2 centimeters lateral to the linea semilunaris. Another complete release is performed down to the inguinal ligament and on top of the ribs. Again, this space is created and the complete release is performed without division of the rectus perforating vessels, and there is no communication with the infected contaminated field with these large flaps. And again, this is the dissection carried up onto the costal margin. This continues on, releasing some of the muscle fibers of the external oblique as they persist on above the costal margin to perform a complete release. Hemostasis is maintained with electrocautery. 10 flat Jackson-Pratt drains are placed in each space. Again, excellent release is obtained with nice overlap in a tension-free manner with the fascia, and again, no flaps are raised in communication with the infected material. Due to the history of infection and the tenuous nature of the fascia, a sheet of 4 by 16 thick alloderm mesh is secured with interrupted fascial sutures with 2 centimeters of underlap to reinforce the repair. 3 liters of antibiotic-containing pulse lavage irrigation is used to clean the midline wound. The midline fascia is then reapproximated over the alloderm to achieve primary repair with an underlay of alloderm for fascial reinforcement. This is the patient at the completion of the operation. The procedure took 3 hours. Bilateral component separation was completed in 45 minutes. The patient was discharged on postoperative day number 4. He did have a small midline wound infection that was managed with packing, and the lateral components were not involved in the infection, and this resolved in 3 weeks.